Good afternoon. We are here for the last session. I believe it's the very last thing before this inaugural forum here in Seoul wraps up. And for that, we've got a very special gathering of people who are really not only key actors in understanding universal health coverage, but really who have the vision, the ideas, and the insights as to how do you make UHC a reality, not just for Korea or where I live in China, but for hundreds of millions of people everywhere who are still without what is essentially an essential basic right. Many of you might know what universal health coverage is to great depth of understanding. Some of you may not, but ostensibly it works off the premise that healthcare is the very basis, the very foundation for a good and better life. Access to comprehensive and quality healthcare being essential for promoting health and reducing inequalities, and not just inequality in terms of access to health, but the social inequalities that evolve from the first set of inequalities. It looks, of course, at what is covered, what services are covered, and how much of the cost is covered. But I think it also goes back to a very basic ethical question. Dr. Tedros, who, as you know, is in his first year as Director General of the World Health Organization, has clearly listed UHC as the banner headline of his term in office. So UHC and achieving UHC will be his priority for his first 5 years as Director General. And he's spoken about it consistently and very passionately about how it links to the ethical question. In principle, he says, will we allow our fellow citizens to die simply because they happen to be poor? He also says that it also brings about the issues of fairness and also the catastrophic health costs and expenditure because farmers, for example, lack the financial risk protection. So he really looks at universal health coverage as a human right. And if that is the case, then we're talking about 400 million people in the world today who are without this human right. As we said, we're joined here by a fantastic panel drawn from different countries, different regions, and different sets of experiences. In brief introduction, we've got Sheikh Mohammed bin Abdullah Al Khalifa, who is the president of the Bahrain Supreme Council of Health. We also have Dr. Kang-lip Kim, who is a deputy minister here in Korea, Ms. Susan Myers, who is a senior vice president at the UN Foundation based over in New York. We've also got Commissioner John Ryo, who is from the HIRA International Group, and we are going to start off with Professor Tae-hyun Kim, or as you say in Korea, Kim Tae-hyun, who is the professor at the Graduate School of Public Health here at Yonsei University. I don't know, perhaps as a start, you can just give me one line first and tell me, Professor Kim, what does UHC mean to you?
Well, basically, I would say, UHC should make, healthcare more accessible and more affordable to everyone. That's what I can say.
Okay, and I know that you put together some thought. Wondered whether we could look particularly at a very sensitive and essential area of UHC, which is drug prices. And we go back to the recent times. It wasn't that long ago, but a different part of our contemporary history when antiretroviral drugs for people living with HIV were so unaffordable that having the drugs was almost, in a way, an insult because it wasn't made accessible, because it just was simply out of the reach of people, even in developed countries. Perhaps we can look first at medicines, drug prices, and take the idea from there in the next couple of minutes.
I think the presentation slide should come up here, but I don't know. Whether it's coming up. But thank you so much for this opportunity today to talk about this topic. I am Tae-hyun Kim, again, professor here at, here you go, Yonsei University Graduate School of Public Health. Let me use this one. Okay. Yeah. Can you believe if a company raised the price of a certain product by 5,000%? I mean, 5,000%. It happens in the real world where the drug named Daraprim was once $13.50, but it went up to $750, which is 5,000% increase. And the gentleman, the CEO of that particular pharmaceutical company, became instantly the most hated persons. Daraprim was not the only drug that went up, that's seen so much price increase. There are many other drugs that have seen a huge price increase. Why is it that problem? Because nowadays there are many patients who have chronic disease, so that they have to have lifelong treatment. Think about yourself. If you have a certain chronic disease, then you have to pay like $750 per day until you may die. That's insane. And patients struggle mightily. They struggle physically, mentally, socially, and financially. And with the enormous burden of drug cost, patients oftentimes they have to skip taking their medications or stop filling new prescriptions. And not surprisingly, as you spend more on your prescribed drugs, you have to spend less on many important things. A recent report suggests that. Do general public think that pharmaceutical companies are transparent about how they price their drugs? No, they don't think so. They hope that they have better information and more transparency about drug pricing, and whatever we can do should be effective to address that particular issue. And sometimes newer drugs are very expensive or super expensive, but actually they may not be that good for patients. They may be only great for pharmaceutical companies, and they sometimes just do nothing but harm or just add more profit to pharmaceutical companies. Here is a successful road to achieve UHC, but the high price of drugs can be major obstacles or barriers. So we have to make efforts to control drug prices. We can enhance more oversight function, and we need to try to enhance the accountability of pharmaceutical companies and their pricing behavior. And then we also promote market competition so that we can introduce more affordable drugs to the market. And absolutely, we also need to develop and introduce our information system to monitor and review both cost and quality of new drugs on the market. And finally, more importantly, actions need to be done. We have to have a good, solid governance. Every stakeholders at all levels need to be engaged, and also we have to put forward collaboration and partnership to take care of. And last but not the least, the role of international organizations need to be very important. We need to step up and take care of this issue. Thank you so much.
Thanks very much to Professor Kim, one of Yonsei's own. And when we were asking you earlier about what UHC means to you, some people also say that all roads lead to UHC. Well, obviously it's going to mean a little bit different to everybody. We put together a special video for you that we've created here at GEEF, and we want to show you what some of the definitions and what some of the emotions are that come from universal health coverage today. Let's have a look at the video.
7.6 billion people live on our planet today. Yet millions still suffer from disease, disaster, and war. The enjoyment of the highest standard of health is one of the fundamental rights of every human being, and it is the basis for the achievement of peace and security in the world. The Sustainable Development Goals, a universal call to action to ensure peace and prosperity for all, also focuses on ensuring the high standard of well-being. One of its core targets is achieving the universal health coverage, a system which strives to ensure that people have access to health care they need without suffering financial hardship. To increase the access to medicines for universal health coverage, the domains of rational selection, sustainable finance, affordable price, and reliable supply systems must come to balance. The price of medicines plays an essential role in access to medicines. In Cameroon, a treatment for peptic ulcer costs almost twice the monthly wage of a government employee. It is clearly not affordable. In low and mid-income countries, the proportion of the people with regular access to essential drugs is less than half of the population, and even those use out-of-pocket money due to lack of government funding. Pharmaceutical companies argue that research and development costs for drugs have been rising continuously, and to compensate, they have to increase the price. However, a soaring drug price does not necessarily reflect a rise in research and development costs or an improvement in outcomes. There needs to be a system to ensure the transparency and sustainability of drug pricing. The solution cannot be developed by the effort of a single organization or a country. Global problems need global solutions. Nations, international organizations, and corporations must work together for a global consensus. For the 7.6 billion today, and for the people of tomorrow, we must start acting now.
Well, thank you to GEEF for putting that video together. I think it really explains some of the succinct issues that we're dealing with. And we're going to hear a little bit later from Susan Myers, who will talk about some of those qualities of partnership and why it's such an essential ally within the SDGs framework and the other way around as well. Let's go next to a very distinguished guest that we're delighted to have with us here in Korea. Sheikh Mohammed bin Abdullah Al Khalifa is the president of the Bahrain Supreme Council of Health. And as its name suggests, it is pretty much the all-encompassing body that brings in the private sector, the military, universities, and also the Ministry of Health on all health-related issues. Sheikh Mohammed, perhaps you can color us with the experience of UHC in Bahrain today, but also maybe stretch it a bit further to what's happening in the region as a whole.
actually is the some kind of network for the population actually from catastrophic spending regarding healthcare, and that's very important to provide the people with this kind of network, and at the same time you provide them with accessibility, quality, equity, and all this actually is the right of people, and that's what we are trying to do. And actually Bahrain, you have a system now of free medical service, but on the old national health system before. So, but we are now trying to change it to a universal health coverage. That's become much more effective and controlling the whole thing. In the beginning, actually, we had begun our trip actually by, through the World Bank, and we had gone through different countries to actually see what their system is and how we can benefit from their experience. We came to Korea because of that, and we actually fall in love with the system that we had saw in here with regarding the IT system. And we thought that, our system should actually be based on this very solid, knowledgeable, and informative information system that we can control the whole thing with it. So, it's not right. Okay. Okay, just want to start it. Oh. Okay, that's actually a sketch of the whole system, and that's very important actually to explain it. That we have actually in the right side actually have the health providers, and the left side we have the health buyers, and the top actually have the controllers of the whole system. But the main important thing about the whole thing actually is the middle thing, which is the IT. And the IT right now actually we have in Bahrain, all the hospitals, the government hospital and also the private hospital, they have their own health hospital information system. And all the government hospitals actually they have very sophisticated health information system, which is make them paperless. But that is not only, that's not actually what we want. We want actually a step further. We actually developed what we call National Health Data Dictionary that actually will facilitate the formation of national electronic medical record, and that means that all the record of every patient in Bahrain, every person in Bahrain is available to this national electronic medical record, and the doctors in Bahrain actually can see this national electronic record and build on it. So if I had been seen in hospital A or hospital B or clinic A or clinic B, if I go to another doctor, he can see all what they had been written to me in this national electronic medical record. The other thing actually we are looking at actually the system, the National Health Information Insurance Information System, and that's what we are getting from Korea. And that's actually controlling all the claims that pass from the providers to the buyers, from the hospitals to the insurance companies. And that's actually will give us all the information about financing the whole system and all the money actually crossing between the stakeholders, and that will give us much more information and control on the money. And the other system actually is the drug utilization review system, and that's actually, we'll come to it later, but that's actually a system that will control all the medication and provide safety for the whole thing. The governance of this system actually is through the departments which we had developed in the Ministry of Health, developed the Department of Health Economy, Department of Quality, and Department of Planning. The main these departments actually looking at the financial side of the system through analyzing all this information coming from HIIS, and this actually will make us controlling the system in all levels. I mean, the whole level and the hospital level and all levels, we are going to have the information, and also we can control every, how much we are spending on this disease, how much was in this kind of things, and that's actually is very important to us. And the other thing actually the quality, and the quality actually are, putting all the indicators and the clinical guidance and everything and monitoring through the quality committee, and make sure that the utilization and is actually, and the output of the system actually is providing the population with a good system. The third department, actually the planning department, and actually the planning department is associated with the training, and this actually medical training, and this actually is the planning that you will plan for us how many doctors we need in the next 10 years, how many nurses we need, how many beds we need, and that is very important actually to plan the services and keep providing a good service for the population. Of course, we have the people actually are working. We are working for actually are giving them a package, which we call it the mandatory package, and which is the mandatory. That means the government actually providing it to the person, and that covers everything. Very expensive, very comprehensive coverage, except cosmetic surgery, cosmetic thing is not included. Otherwise, everything is included. And there is no any kind of financial payment for having a service in the primary health care. And the primary health care actually are developed that based on family physician, and everybody is going to have his own family physician, and the family physician actually is going to reward by a capitation system. It depends how many person actually registered with the doctor, and according to the number, he's getting his capitation. And that makes some kind of competition between the doctors to give a good service for the population. The same thing, the patient actually has a choice to go to any hospital they want, and that's actually make another competition for the services for the people, and that we think is going to benefit the people. That actually is the NIMR, which is actually National Electronic Medical Record. Actually, it's actually not only a National Electronic Medical Record, it is a National Electronic Medical Repository in the same time. All the information actually comes from all the aspects of providers and the buyers. It goes to this actually National Electronic Medical Record, and we are actually putting a system which called the utilization system, which is SUN, which is actually we are this reporting system where we can get reports for all the stakeholders. I mean the internal stakeholder, even the external stakeholders, they can get all the reports, if they are allowed to automatically without actually consulting us, because they just set up that this body can have all this information. And that's actually facilitates that we put the information once and get reports once. The drug utilization system actually is very important to us, because as you had mentioned, you had said that the drugs is very expensive and we must control it. We in Bahrain and the Gulf countries buy the drugs collectively for the whole Gulf countries, and that actually make it much more cheaper for all of us. And in Bahrain, actually, we are actually planning to have a PPP, or a public-private partnership company, which are going to buy these drugs, through the tender which we are arranging, and storing it, distributing it, and actually, to the pharmacies and to the hospitals. And actually, this system will provide safety for the drugs, because it's actually the check that the medication that had been issued to is the proper dosage, and there is no interaction between these drugs together. And at the same time, there is any allergy or something from sensitivity from it, that make safety for the people. And that's, I think, is in summary, we are getting the governance of the system. That's information integration and analysis and reporting, and planning of health services and resources, and health economic and health technology assessment to ensure optimum utilization of health resources. Health quality and clinical guidelines management comes with KPIs, setting audit and control. That is the function of the governing body. Regarding the electronic medical record, we have the one repository of all related health data. Connectivity is unlimited. Real-time access to all patient electronic record. Enable full analysis, capture from different data sources, and eliminate duplication of services across the health system. And this, we think, we are going to have a better quality and safety service for the population. Regarding the drug utilization review, as I said, it's going to provide the right because of this, buying collectively for the whole countries. In brief, I just want to go through what's happening in the Gulf regarding the universal health coverage. In Saudi Arabia, actually, they had begun this actually by covering the private sector in the late 90s, and then nowadays, actually, in the last 2 years, when they announced actually the plan for 2030, they are working actively actually to cover a universal health coverage for whole the kingdom. They actually have a system which they are going to develop one company, one holding company. From that will stem 5 holding companies, and these 5 holding companies actually is going to be everyone responsible on one region of Saudi Arabia. Saudi Arabia is a big country, and these 5 holding companies will buy the service from accountable care health companies, and they are actually going to be paid according to capitation. I mean, if this company is responsible about an area with 1 million, they will give the capitation of 1 million for full service of this population. The UAE actually had begun in the late 90s, and actually they began the system by covering all the private sector, I mean the expatriate private sector, and then they expanded to the population by a system they call Thiqa. And Qatar actually had started, but because it started in the 15th and the 19th, 2015, but when they implemented, they found that is very expensive and very, very controllable, and they stopped it in the within a few months. Kuwait and Oman are actually providing health coverage for the expatriates, but they still working actually and thinking about covering the whole population with the system. Thank you very much.
Well, that was a very detailed look at what's happening in Bahrain and also the Gulf. We're going to move now to the center of the room to Dr. Kang-lip, who is the Deputy Minister for Planning and Coordination. And we're going to look at what's happening now for over 50 million Koreans living here today. UHC is by and large a dream that's a reality. How did you manage to do it, and what are the essential lessons that everybody watching on the live stream can try and emulate from Korea?
Okay, thank you, James. First of all, I wish to start with my presentation by expressing my appreciation to the organizer and also for inviting me to this very meaningful discussion. The universal health coverage is a big challenge for the Korean government in a long time ago. So we achieved the world record to achieve the universal health coverage for the 50 million population size. It took only 12 years after the initiation of the health insurance in this country. So followed by the Japan, we took the shortest time in the world. But the time itself is just one thing, because we have many challenges so far. So today, I'm going to share with you some the Korean model from the perspective of how can we provide the benefit for the global reference in the area of drug pricing. Please show the slide. So because theoretically 97%, almost all the Korean population are covered by the national health insurance, and we adopted the fee-for-service system from the first the adoption of this policy. So we can make we can accumulate the big data. So by using this asset, maybe we can contribute for the the better health of the people by providing the, the more evidence-based or value-based approach to pharmaceutical pricing. So the universal health coverage can achieve not only by the one single factor. The several factors are required for the successful achievement and operation of the healthcare coverage and the health insurance. So I can say that the universal health coverage in Korea is the key success factor of good health outcomes in Korea now. We spent only 7% of total GDP for the health expenditure among the total GDP, which is compared to the OECD average, is lower than the average of OECD. OECD countries usually spend 9%, but the health indicators shows that our health status is better than the average. And behind this successful story, the health insurance and the universal health coverage is the key success factor, I can say. And today, in operating the health insurance, national health insurance, one of the key factor is how can we achieve the financial sustainability. As it is already mentioned by the Professor Kim's the presentation, the pharmaceutical expenditure accounts for more than 16% of total health expenditure among the OECD countries. And my country, my government spent more than 21% so far. In 2016, we presented 25% on the drugs. And furthermore, as I already mentioned, the drug price is soaring. And maybe I can show you several figures. In the United States case, you can see that how fast the drug price is going higher and higher in a short period of time. So on the other hand, for the cost aspect, the financial burden comes from the drug price and the expenditure on the drug. But how about the benefit? It is very clear if we pay more, if we can get the more concrete benefit from these high prices. So far, unfortunately, it is not so clear. The high lunch price does not always coincide with the improvement in benefit. And also, according to recent study released by the EU, and that the only 35 cancer drug shows the improvement in survivors, which is studied during the period of 2009 until 2013. So it means that almost half of the cancer drug still remained in the market with uncertain evidence. So as I mentioned already, maybe the Korean model can provide the very useful reference to serve this the uncertainty. So the real-world evidence, by using the national health insurance big data in Korea, can provide a very useful tool to review the approval process of regulation authority, the Korean version, the FDA, the MFDS, and also the listing price of the national health insurance, which is currently managed by the HIRA, the Health Insurance Review Agency in Korea. So we can provide the very useful tool to review this process with very concrete evidence by using the real-world data. So as I mentioned, the Korean National Health Insurance Scheme covers the entire population, and also we adopted people services, and thanks to the very advanced information technology, we can analyze theoretically with this data, and that nowadays the Korean government and the Korean academia is focusing on the common data model, which is made for the distributed research network, and the most important characteristics of CDM, the common data model, is The one is the standardization for medical terminologies and data structure analysis. So with CDM, not only for the, the government side or the public side, but also the academia and researchers, they can utilize, this CDM for their own purpose. And the other issue is that the privacy issue, because it's a very sensitive information. So with the CDM, it is free from the privacy issue of healthcare. So these two characteristics, it can be utilized for the not only for the Korean the stakeholders, for the global and the international researchers. So recent pilot studies has been performed by the several the agencies, and I can share with you just one case, which is performed by the HERA on the anti-platelet drug for PCI patient. Because the PCI patient with ACS are recommended to use the next generation drugs, which is more expensive than the previously used drug. So they analyzed these two groups. One group took the previous drug, the cheaper and the traditional drugs, and the second group used the next generation, more expensive drugs. So they took the Atlas tool as analysis method. The outcome is somewhat different from the expectation. At the International Medical Society, it is recommended to use the next generation drug for the PCI patient. However, in Korea, the outcome is somewhat different. For the revascularization, the next generation drug is useful in some sense. However, for the major bleeding risk, the next generation drugs have a higher risk than the previous one. So with this kind of evidence, we changed the benefit guideline for these people. So I can show you that this kind of model. So we can make the DRN, the research network, at the publicly or on private side also. So which the leading hospitals can provide their the CDM to the the DRN of a private DRN, and the public DRN comes from get their the CDM from the health insurance and the National Cancer Center and the Korean CDC. So if we provide under the supervision of Ministry of Health and Welfare, if we can provide a relay center, the research request and the provision of this kind of data could be connected. So it is one example that how the Korean model or the universal health coverage, and also how can we overcome the the global challenge from the the increasing the burden of the high the expensive price of new drugs, and as a summary, I can summarize my presentation with some the implications that with my presentation. So with this kind of effort, we can reduce the pharmaceutical R&D cost and development period. So it's not only beneficial for the the government side or health insurance side. Also, it is very useful for the the industry side. And the other aspect is that through this kind of evidence, we can get the more concrete and cost-effective benefit management. So nowadays, Korean government is planning to introduce the reassessment system for the the already included medical services and the drugs. The other one is that the real-world evidence can provide the more acceptable solutions, not only for the the government side, also for the the physician side, and also medical doctors and the physicians also, patient also, because with the real world evidence, the more reasonable decision making can provide the acceptable solutions. And lastly, it could be used not only for the domestic purpose, it could be utilized for the global level. If we can provide the more reliable index, which can determine the efficiency and efficacy of the certain drug, we can have a more powerful tool to determine the pricing of the future drug. Thank you.
Thank you very much to the Deputy Minister for that insight into UHC today and what it means to Korea and to millions of Koreans, what else that we can bring out of it as well. But, I want to go over now to Susan Myers, who is a Senior Vice President at the UN Foundation, which some people don't know is not actually part of the UN, but is such a close partner to it. And her title is very reflective of the different roles and the different ways in which she helps bring it alive. She heads up the office over in New York, but also equally important, she helps the foundation build and strategize its long-term vision. Susan, I also noticed as we were coming out today that you're the only woman on this panel. So we're going to be talking about universal health coverage. I think that this time next year, the organizers should have at least half, if not more, women on this panel of 5 or 6 of us. That, of course, is not the reason why you're asked to speak today, but rather the insights that you bring. When we do a TV show, I always think to myself, no matter how interesting I think the subject is that I'm speaking about, why should anyone care? And so if this is your television audience today, could you perhaps tell them why they should care and what the alternative could be if they were living in a world with no UHC?
Thank you, James. I'm very happy to do that and to bear the heavy burden of being the only woman on the panel, which I think is reflective of the heavy burdens that women face around the world when it comes to achievement of the Sustainable Development Goals. Thanks also to the Yonsei University and the Ban Ki-moon Center for Global Citizens, and really to Ban Ki-moon himself for the vision and leadership he's shown for many years, including during his time as Secretary General. I think it's a true testament to this leadership, why so many leaders were here as part of this conference today, and I had the personal opportunity of supporting him and working with him, and it was a true pleasure. I think it's really appropriate that we're talking about universal health coverage as one of the main topics of today's Forum on Sustainable Development, because I think it's becoming more and more clear that UHC is inextricably linked to achievement of the SDGs. The development community learned from the Millennium Development Goals, which came before the SDGs, that we needed to move away from approach of just traditional providing aid to developing countries as a way of solving global poverty. And we've moved much more to an approach of empowering countries. And the more ambitious and comprehensive SDGs really make countries the architects of their future. And I think universal health coverage really embodies this kind of approach. It's really a movement. It embraces a lot of the same principles that the SDGs stand for, so country ownership, equity, the integrated approach that we need for the SDGs. And James, you didn't ask me this particular question, but what universal health coverage means for me is really that it's a core component of leave no one behind. The former Secretary General referenced this phrase several times in his remarks earlier today. And I think that universal health coverage including in my own country, really helps stand for this principle of leaving no one behind, because it's certainly fair that an individual shouldn't have to make choices that bring themselves into poverty or prevent them from having access to a lot of the other things they need for their overall well-being, just to be healthy and certainly to prevent life-threatening diseases. So achieving UHC obviously is an important part of SDG 3, so the Sustainable Development Goal related to health. It also has benefits far beyond health outcomes, including the potential to either prevent individuals from falling into poverty or to reducing extreme poverty. According to the Lancet, which of course puts out a lot of expertise related to health issues, 800 million people spend at least 10% of their household income on health expenses. And for 100 million of those people, these expenses are enough to push them into poverty. The good news, though, is that there is a lot of global attention to, and I think more and more momentum around this issue of universal health coverage. James, you mentioned the relatively new Director General of the World Health Organization, Dr. Tedros, who has said that UHC is his top priority, and he's integrated it into the organization's program of work through 2023. And there are a lot of other individuals, including at the UN and elsewhere, who are prioritizing this topic. And I'm going to walk through some of these because I think some of these are opportunities for the individuals in this room to get involved and speak out on this important topic. One of the newer initiatives that's been launched is called UHC 2030. It was launched in 2016, and so far it's brought together 66 countries, a host of organizations including the UN, World Health Organization, of course, the Global Fund on HIV/AIDS, also foundations like the Gates Foundation, Rockefeller Foundation, and my own organization, but many others to strengthen health systems and accelerate sustainable progress towards healthcare for all. So look to UHC 2030 as a way to get involved if this issue is compelling to you. During a forum that was held by the UHC 2030 just at the end of last year in Tokyo, a number of high-level individuals came together. Countries like Japan pledged $2.9 billion to support healthcare in countries that are implementing universal health coverage. So again, there's quite a lot of momentum here and a lot of positive movements to associate with. The elders are another group that's come together and spoken out on universal health coverage. The elders, of course, represent a number of world leaders, including both of our two previous Secretaries General, including Ban Ki-moon, but also a lot of other former heads of state. They were brought together by the late Nelson Mandela in 2007 as a way of harnessing leadership and voices in support of a number of important issues. They took on universal health coverage, knowing how important it was to not only health, but a number of other issues. And they've actually made this issue part of their Walk Together campaign, so hashtag Walk Together, which began last summer and will continue Nelson Mandela's long walk to freedom. This was, of course, inspired by one of the many wise things Nelson Mandela himself said, that health cannot be a question of income. It is a fundamental human right. And he said that back in 2003, and we're still working on it. So clearly, we need all of the help we can get. Since I am the UN voice on the panel, I just want to talk a little bit more about some of the ways that the UN is working on this issue. Of course, as you saw in the video, the universal health coverage is part of the Millennium Development Goals, so it's officially there. In addition to Dr. Tedros, UN Secretary General Antonio Guterres has also made universal health coverage a priority. He attended the forum I spoke of in Tokyo last year, where he described health for all as key to a more sustainable, inclusive, and prosperous future. And he said, by investing in health, we're investing in more inclusive and resilient societies, which is a core part of the Secretary General's priorities. And it's great that he's put his voice behind UHC as part of this. The UN is also planning to host a high-level meeting in New York next year in September of 2019 on universal health care. This will happen at the same time that world leaders come to New York for a review conference on the SDGs. This is something that happens at the head of state level only every 4 years. So it's a really important opportunity to talk about universal health coverage at a time when the whole world's attention will be focused at the highest level on the SDGs. And we've often seen the UN has a lot of meetings. I'm the first to admit that. But we've often seen that high-level meetings like this can be really important drivers for progress, especially if we plan and use key moments on the way in their planning to bring forward new commitments and new forms of leadership. So speak out to your government leaders, to other leaders that you have voices to affect, and encourage them to take this meeting at the UN seriously and come to it with concrete examples of progress, because that's what we really need. I will just end by just saying a quick word about how important the private sector is. Obviously, you've heard from all of the presentations here how much drug pricing and the role of the pharmaceutical industry impacts universal health coverage. So I'm happy to maybe spend a bit more time in our Q&A talking about partnerships and including some of the really effective ways that we've seen corporate leadership on health that can be models for addressing universal health coverage as well. But I'll end there for the sake of time. Thank you.
As Susan indicated, she'll be happy to take some questions afterwards. And I think also, perhaps, Susan, we can think around one of the big calendar events that you highlighted was the end of 2019, or not really the end, it's September, isn't it? September 2019. So let's just say 18 months from now, by which time some people here in the audience would be halfway through their degrees or may even be freshly graduated. So I think you can challenge Susan and anybody else on what you would like to do. And if the last 2 days have infected you with a spirit to move on SDGs, then how can you play an individual role as a representative of your own community? And you're here in one of the finest universities in the country and in the world, I think, as well. So you're in a particularly opportune place in time in life. And I think, as Jeffrey Sachs said, I'm not sure how obvious it is because he is Korean as well, but you really have the global architect of the Sustainable Development Goals choosing to be at Yonsei University. Ban Ki-moon's legacy and ongoing legacy can't be underestimated at all, because it's more than changing the world, it's bringing about a positive transformation. It's much more than the talk. It's something which is far more solid than that. So think of any questions that you want to ask. You can raise your hands. You can put them up on the Facebook page, the IGEE Facebook page. But as you begin to think about the questions you want to put to our speakers in this very last session of this forum, may we hand off to Commissioner John Ryo, who is the Commissioner of HIRA International. HIRA, you would be very familiar with here in Korea, is the Health Insurance Review and Assessment Service. So he's going to talk a bit about how you change lives the way he sees it. I think he sees every single claim, or HIRA does. So he sees that change before his eyes happening. And John, as you do, what insight does it give you?
Thank you, James, and also very excited now to sitting next to Susan. And Susan is my former colleague at United Nations Foundation, and certainly my experience at United Nations Foundation was focused on working on the MDGs, where they're eradicating the malaria net zero campaign, and also the supporting the young girls in the refugee camp to enhance their life as well as education. So just reminds me of my old days. Certainly the working for SDG is a very also much, personally, I'm excited because the where that MDG work I was doing, it was under the leadership of Ban Ki-moon, and as well as the SDGs where that he architectured this SDG. For the where the as UHC concerns that one is certainly the UHC is part of the SDG, and what's important piece is that where everyone in the world get quality care without financial burden, and anywhere you stay. So what's happening in terms of here in Korea, this is a very recent phenomenon that we see many Koreans live overseas, come back to Korea and get medical treatment because it is a good quality, it is affordable, I mean extremely affordable, and also gets good aftercare. That is what's happening now. And also we have not the positive sort of phenomenon, but we can see hundreds of our neighboring countries, the cancer patients comes Korea to get treatment as well, without paying a reasonable amount of cost. The universal health coverage is affordable, equity, accessibility, good health care service, financial sustainability had to be secured. And certainly that countries, the past 4 years, I've been working with over 35 low-income and middle-income countries. And among them, the HIRA conducted gap studies where that they can develop enhance the capacity building process. The challenges are pretty much the same. The rapidly increasing of senior population, catastrophic expenditure on NCDs, and especially the price hiking of new drugs, and ever-increasing healthcare cost. The countries have different solutions, and there is no one solution can cope this problem. But there is certainly very important piece that country must have is the evidence-based measurable system, which certainly will help the enhance quality of service. Also, this will change behaviors of the providers. This graph shows the life expectancy and the health expenditure. Well, that U.S. spent 17.2% of the shares of GDP, and life expectancy is 79 years, and where the Japan spent about 11% of GDP, and about 84 years, and Korea here, as the Deputy Minister Kim mentioned, that one of the health indicator we spent less than OECD average, about 9%. We have this is about 2015 report where that 82 years old is the lifespan. So this certainly the indicators show that when the country effectively and efficiently they use it's the resources with the measurable system, then we can certainly make the great result, positive indicators, health indicators, without spending that much. The HIRA is standing for Korea Health Insurance Review and Assessment Service, and this we are commissioned by Ministry of Health and Welfare, and they conduct our mission on behalf of the Ministry of Health and Welfare of Korea. It started about 2001 at the point where that before HIRA, there was the annual increase of our expenditure, healthcare expenditure was about 20% increase annually. And starting from 2001 until 2015, and as you can see the graph, where the annual increase is monitored, and it's achieved 8.8% increase, and there were projected spending by 2015 versus actual spending, there are 12.5 billion US dollars has been saved. So this, the whole process where that we are able to build the ITC-based, evidence-based measurable system, what inducement of providers' behavior we show, one of a quality indicator can see. The 2003, when we did conduct a study in terms of the way as measuring the prescription of the antibiotics used for common cold, there were 73.3% cases that doctors, providers prescribe antibiotics. And then this annual, the quality assessment being done, and the report goes out to Ministry of Health, and then the ministry opened this information to public. What's happened is gradually the providers reduce in terms of the change their behavior pattern, prescribing the antibiotics. And in 2015, we found that 43.8% prescribing the antibiotics for common cold, we call also upper respiratory infection. This shows two very important elements. One, without this quality assessment, this pattern had continued. So unnecessary antibiotics prescribed, where is one, the safety issue, and the second piece is that with the 50 million people, and you can see how much of the waste and money-wise saved by dropping this radical drop of the prescribing antibiotics. And then so when we can show you all the evidence how the induce the provider's behavior with the scores. The very recently that probably 3 weeks ago, U.S. Chamber of Commerce delegation came to Korea. Including the part of delegation were the representatives of big pharma as well as the big medical device companies. And their claim was that the HIRA does not value or respect the innovation value by the creating the new drugs or new machines. And our response to them was, show us the evidence-based scientific data that why we should pay that much. As long as that you can provide us, then we will talk with you. But it is very simple and easy. You have certainly the upper hand in terms of produce drugs for the cancer and etc. disease, and certainly that I'm traveling around the different countries, and especially as I mentioned, the low-income and middle-income countries, and the drug price has been big burden. As the Deputy Minister Kim mentioned, the Korea's case is about 25% of our healthcare expenditure is drug price, their cost. So what our part here, HIRA, does is the last 15 years, we developed ICT-based system to value what we purchase, and also to see that how we can effectively and efficiently use resources. And that system is now the first time in the whole world we are working with the Kingdom of Bahrain to build Bahrain's national health insurance system. And now that turns into the Saudi Arabia and Dubai and Arab Emirates and Oman and Kuwait would like to see what is happening in Bahrain to how they can effectively, efficiently also use this system. So what I think the knowledge and technology that we developed here in Korea can be shared, can be transferred to other countries. That means other countries do not need to reinvent wheel. There are quite a lot of the saving effect. When we promote UHC worldwide, we really got to work together globally. And many the speakers this conference mentioned that how the domestic the work can affect globally. I think this what we need to do is really the committing ourselves that whatever good practice we have, good technology we have, good knowledge we have, we're willing to share with the other countries, especially those the low and middle income countries, and hope that one of the action comes out from this UHC panel is the hope the Ban Ki-moon Decisions Foundation as well as the create an effective platform for the international healthcare purchasers network. So when we deal with the buying the drugs or the implementing new technologies and implementing national health insurance system, hopefully that we are united, work together. And this is what I would like to suggest to this conference. Thank you so much.
Thank you to Commissioner Ryu and to all of our speakers over here. We're going to open up that space now for questions. We've only got about 20 minutes, and then you can all go home or do whatever you do on a Thursday night in Seoul. Let's take some questions from the audience. Who wants to put a question to one of our speakers? Just raise your hands. Great. So I think we've got 2 questions at the front. We'll take these first 2, and anybody else, just let me know. It's John Lee.
Yeah, it's me. Hi, I'm John Lee. I'm a researcher here at the IGEE and Yonsei University. I would actually like to ask a question more about the concept of UHC than about its mechanics. Its very term suggests that it's supposed to be universal, and we would like to include as much as we can, as much people as we can into its service. But I think the term has come up very frequently this morning, is that this is the age of migration. We have a lot of people that are migrating from one place to another, and maybe even in their own countries from one place to another. Many of these are legal with great financial backgrounds, with great stability, but again, a lot more are actually in forms of refugees, in forms of very poor people that just cannot survive at their homestead and has to find some other ways of living, and they're just taking pure chance by coming to this another country. And one of the very unfortunate things is that they are not very well covered by wherever they're moving, that the health coverage doesn't really cover these new migrants because technically they are illegal. I was wondering, and I'm asking to everybody on the panel, how is your organization handling or trying to include these people into your view and your vision of UHC?
Okay, who wants to go first? John, Rio, do you want to go first? Okay. Okay, so we'll go with Deputy Minister.
Yeah, it's a very hard question because there are very diverse solutions for this kind of challenge. As you mentioned, there are more the mobility of the population across borders happened all the time, and the number of the moving population has been growing, and also from the perspective of the government side, it is not always easy to find out which group that we should take care of. So maybe there could be several solutions. For let's say about the Korean cases, as I mentioned, we covered all the registered people living in Korea, despite their nationality, who are legally living in Korea. All the people are covered by the national health insurance. So theoretically, currently, we covered 97% of the people living in Korea. But the other people are also covered by the national Medicaid system. But still, frankly speaking, we lost some people now. We cannot cover all the people with these two schemes. There are some, the refugees and some, the illegal migrant and illegal migrant workers. So from the Korean government side, we are trying to reduce the number of these kind of people. But at the regional level, at the global level, there are other the regions that each government cannot cover all the people, even though they set up the universal coverage system within themselves. So with the support from the international society, the international agencies and the international the NGOs, maybe the government side can work efficiently in the future. But it depends on the situation that every country has been on. Yeah?
Okay, who else wants to speak to John's question?
I just would have a short comment that I think this is part of the reason why the United Nations has prioritized finding a new approach on migration, because it does affect so many other issues and will continue to prevent us from achieving probably many aspects of the SDGs if we don't find more ways for migration to happen legally. You heard the Secretary General and the President of the UN General Assembly talk about this issue earlier today, because there's an ongoing UN process that will hopefully result in a new approach on migration and a meeting that will happen in Morocco at the end of this year. So the recognition that migration affects so many other issues is something that's very much on the minds of leaders at the UN.
I mean, that's the point, isn't it, Susan, that when we talk about all roads lead to UHC, I mean, it means that literally. And it bounces off the very design and spirit of the SDGs, which, unlike the MDGs, which took everything individually and vertically, we built on that successful model and improved it even further by allowing the 17 goals and the hundreds of targets between them to almost bleed into each other. So when we look at these colors around the GEEF logo, yes, we can see 17 separate bars of color, but in fact, they all sort of swim into each other. What does that tell you? I mean, apart from migration, what are the other opportunities that you can sense? And what would you tell everybody here in terms of where you feel we're headed and what we should be prepared for and how we can anticipate that?
That's the other point I was going to make in terms of what you can do to support universal health coverage. It's really supporting the Sustainable Development Goals as an overall framework that governments and others take seriously. Governments, of course, agreed to this framework in 2015 when it was adopted. From somebody who's worked around the UN for many years now, I would say it was probably the high watermark in terms of multilateral cooperation, seeing world leaders come together around an agenda as ambitious as the SDGs. But just like universal health coverage relates to so many other aspects of the SDGs, other aspects of the SDGs are also part of the enabling environment for universal health care to succeed. So just making sure that you're using your voices to let the world know that we have the SDGs. Not everyone knows about them yet because they are still relatively new, but also to remind governments that this is something they agreed to and are really need to put solid commitment and resources behind, I think it seems like a basic thing to do, but it's still really important at this point in time.
And I think even the Secretary General said, get involved in politics. Don't reject politics, don't reject the established system. That's the way that you can articulate your voice and ensure that it counts to a great extent. So to be part of the power sharing, I suppose he was trying to say in that particular context. Okay, so I think we had another question from the gentleman at the front.
Yeah, my name is Park Robyok, working at the Secretariat of the one of interesting conference for the political parties. My question goes to, I think, Susan Myers and particularly Dr. John Liu, because you have both of some of the panelists mentioned that interesting point. One of the biggest challenges in the medical sustainable goal is the hike or overpriced medical medicines imposed by the pharmaceutical companies. But the pharmaceutical company are also countering their argument to mention that the cost of innovation, etc. As a consumer or as an ordinary people, it is very complicated area. So, Ms. Susan Meyer and Dr. John Liu, could you explain what kind of actions or measures could you recommend at the international level as well as the national level? Because the UN or WHO has expertise, and also at the national level, you have many the medical control agencies. Could you solve by this kind of expert organizations? And could you elaborate how we cannot, ordinary people cannot demonstrate with a play card in front of the pharmaceutical company without substantiated argument? Could you give us a good solution so that we can have a more reasonable price for our medical treatment? Thank you.
If I may, I will have the Susan answer about UN aspect, but I will just mention a couple of things for the national aspect. I remember the February 28th, 2017. There was a sort of a doomsday for big pharma in US. What's happened that day is, this is approach. The 5 senators and some lawmakers in Hill introduced a bill called Drug Importation Bill, which is the US government will accept the importation of the safe and also the good price drugs from overseas, particularly aimed to the Canada. This also include re-importation. What re-importation means is that the drugs produced in US, which sells 3 times, 4 times higher than price selling in Canada. So re-importing drug, US drug, back from Canada to US. So that bill is introduced. So far, that bill has not been passed because the big lobbying from big farmers still is hanging there. But however, this the key introducer, author of this bill is the Senator Bernie Sanders, and he is getting more votes in terms of support from the senators and lawmakers. But I'm watching this because this is, as you understand, U.S. drug, the drug law history, where the Medicaid and Medicaid, government cannot negotiate the price with the pharmaceutical companies. That's the way it's done. So what the domestic, in terms of the U.S. is working that way, as I mentioned before, we would be willing to engage in discussion with the pharmaceutical companies if they are able to generate evidence-based scientific data why the cost of drug, price of drug is that much, and try to see how we can work with them. So, and then another piece is this, to really countries get together. There are in terms of the medical service purchasing, the institutions, each country, on behalf of government or the part of government, and federation or the alliance together and to build the negotiation power, or they build a strategic purchasing process that how we can buy the drugs low price. Or, I mean, low price doesn't mean that hurt the innovation value. If as long as we can they can justify innovation value, there is the volume that the countries together can buy, and somehow that the big volume can decrease the price.
I will admit I do not know as much about the mechanics of how international organizations are dealing with the issue of drug pricing, but what I do know is that the UN can be a really effective platform for shining light on examples of when a sector is collaborating in a good way to advance UN goals. And I think we've seen emerge some good examples of how the pharmaceutical industry is collaborating across their sector in support of issues like non-communicable diseases and developing new drugs to address NCDs. And the other thing I'm aware of is that not necessarily at the UN, but in part catalyzed by UN leadership, including on the SDGs, is that we're creating a number of tools to try to create more transparency and give consumers and citizens the tools they need to better know and rate which companies are doing the right thing in support of the SDGs. There's the Access to Medicines Index, for example. We're part of a new emerging initiative called the World Benchmarking Alliance, which is meant to be a tool to rate corporate performance on the SDGs, and to do this in a very transparent way, so any citizen can look and see rank companies within a particular sector or around a particular part of the SDG agenda on whether they're doing the right thing. So we have, I think, some new ways that citizens can know what's going on and use their voices to speak out when the right thing is not happening. I don't know if others want to speak on this topic.
Right. I actually did have a question for you on partnerships, but I turned to Facebook and there are a couple of questions waiting there online for us. And Tori, who I think might be in the room, maybe. Tori says, can you elaborate on how countries can work together to ensure UHC for their citizens, as so far this remains at the national level? What are the opportunities and challenges for third world aid receiving countries regarding this issue? Well, first of all, the SDGs and UHC is for everybody, it's not limited obviously to the few. But I suppose if what she says is right, then that's another argument as to why we need a strong UN and why we need the UN every day. But I'm sure it's not just posed to Susan, but to anybody here on the panel, including Susan. What would you say in response to that? How do you get countries to think out of their box? You know, I interviewed Mr. Ban in November, and he said something, you know, that really, really struck me, because I've seen it with one or two leaders where you see them on the world stage, at the UN, at the General Assembly, and they're brilliant. You know, they really have gravitas. And then you read their own national newspapers back home when they return, and it seems like two very different people. And Mr. Bunn actually picked up on this, and he said in the interview that there are statesmen and then there are national leaders. So therefore, there are people who continue thinking in their own small way. They would go to the General Assembly, they would be the world leader, but when they go back home, they allow themselves to get caught up in local petty politics and local agendas. But there are statesmen or stateswomen who transcend that. And no matter where they are, they carry that same consistent message no matter where they are. Do we have that now? Is there evidence that that we have leaders who are thinking outside of the national box, who are ready to take on issues like UHC, but not only limited to UHC? So we can just blow this wide apart beyond UHC, because UHC is related to everything that we do. Do you think there is evidence in the geopolitical space that there are good leaders who can take up the globalization mantle even? Does anybody come to mind? we're in real trouble if we can't come up with one name between us.
Yeah, I mean, I think first of all, I personally have been engaged with several knowledge sharing projects, KSP projects, particularly on the topic of UHC. I mean, even though Korea, for example, achieved UHC earlier, that doesn't necessarily mean we are perfect. We still have so many issues to take care of, and when I went to several Southeast Asian countries or Middle East or other countries to share our own experience, I sometimes get a very innovative ideas or experiences from other countries' side, and so we can share a lot of what's going on in both countries or sometimes several countries. So by doing that kind of a project or by creating environment of talking and learning each other, I mean. Particularly if we can engage more higher level government representatives, then again I think we can put this issue into a global level, certainly. So I would say that we can keep that kind of project going more often and more frequently and globally, and not nationally or domestically.
Just echoing the several the project going on in the supported by Ministry of Health and Welfare. One of the project fund is the late WHO Executive Director, Dr. Lee Jong-uk Fund, which is designated to support many health issues. Also, that also includes UHC as well. For example, when we provide training to the delegation from Ghana or Ethiopia or Philippines, the system, IT system these countries have versus what HIRA has, pretty much the difference is, you can say, speed training versus the steamed training. So there is no comparison to really how to say this. But when they see this difference, they say, well, this is not something that we can have. But that's starting point to dialogue, where that because they are not politicians, they are not the policymakers, we bring the practitioners come and then show what is the philosophy or the ideas behind this IT system, which is pretty much policy, pretty much also what the research-based, what experience-based, what is the good policy and good regulation. And this discussion engaged, and then the second meeting, a third visit, what's happening is, in case of Ghana, they started to build the automated claims review system, not comprehensive as what we have, but the concept itself is so smart. And they can start with the district and then able to provide the dashboard, which statistics will show the quality as well as the money spent. And it end up showing in terms of improvement, whereas the prevent waste spending and then prevent fraud and increase quality. So as we don't need to really engage in the policymakers and the government. There are many, many examples how the practitioners that the different countries engage together, produce very the tactical, clever idea which meets local context to enhance the capacity of the national health insurance or the medical quality medical service or capacity of the health service in that country.
I found a way of bringing in the partnership issue that also is related to this question, because I think part of what government leaders need to do is not just get behind universal health care and put more of their own domestic resources into it, but also create the right kind of environments in their countries where more private sector activity and investment can be unlocked. So one example I did want to call out is actually something that's happened in Kenya that was catalyzed also by the leadership of the former Secretary General Ban Ki-moon, because back in 2010 he had the vision to help create something called Every Woman, Every Child. This was because the Millennium Development Goals related to maternal and child health were at the time the furthest behind. So he brought together governments, the private sector, academia, and others to create this movement. And this movement helped catalyze something called the Kenya Private Sector Health Partnership, which was launched in 2015 and included collaboration of the Kenyan government, the UN, and a number of companies, including not only companies directly related to healthcare, but also companies like Safaricom who are engaged in telecommunications. This has been a really effective partnership that's addressed maternal mortality in some of the parts of Kenya that had the highest number of deaths from this issue. And so just finding ways for the government to directly engage with the other sectors that are needed to be part of the solution, I think is also something that we need to see from political leaders.
Thanks very much, Susan. We have more questions. I just saw one over here on Facebook as well. And it's from another of our students who asks any of you this question over here. Now, let's scroll down. To achieve UHC, this is from Harry, to achieve UHC, there needs to be more transparency and insight into the health status of the citizens themselves to determine who needs what type of service and when. Thus, a healthcare system that runs on insightful, continuous flow of data seems like an important factor to achieving UHC and leaving no one behind. Harry, this is a very long question, I'm still reading. What are the key requirements needed to set up a data system in countries where there's a lack of continuous data flow due to a lack of infrastructure? What kind of data should be collected, cleaned, and analyzed for countries that are now beginning to establish a health data information system? What is the UN doing to provide support to countries that are trying to establish a health info system? So we can take that in different ways. Professor Kim, you're looking at me. I think you want to say something.
Yeah, I mean, let's see, tough question. So what kind of information should we collect, right? I mean, sometimes, yeah, individual patients may do sort of, moral hazard things. It happens here in Korea as well. I mean, you may want to do medical shopping. You see this doctor and that doctor, and you go this hospital and that particular hospital. So I mean, we need to check. I mean, why they are doing it, and why they are wasting health care resources, and we should monitor. I mean, their health utilization, information, particularly whether or not they are receiving too many, drugs. Sometimes drugs can, act each other, and they may harm to, patients. And also, we have to have a so-called gatekeeping system, so that each patient can use healthcare at more appropriately and at a better level. Although we're trying to do that, but again, we're not 100% perfect, and so hopefully we can come up better idea to reduce so-called again moral hazard things, and also I think the government is trying to introduce so-called value-based insurance system. For example, if patients wants newer but not so good new healthcare technology, then they may have to bear higher out of pocket payments. On the other hand, if the patients are more regional and rational, then they can choose more affordable drugs and healthcare technology.
Sheikh Mohammed?
It's actually what kind of service you want to give actually to these people who are actually don't have the service in their own country. The most important thing, in my opinion, is primary health care. If you provide good primary health care, which is usually much cheaper than secondary health care, you are actually controlling and preventing a lot of diseases. And the information that will come from this primary health care will be very effective actually in controlling mother cares and children health. It might not be that good regarding the chronic diseases, but the chronic disease usually affecting the old people, and all the treatment we are doing now is actually not curable, actually just delaying. So I think we put our priority, we're going to put our resources, we're going to put our efforts actually to give the best benefit for the population.
I am working Mohammed to building the Bahrain's national health insurance system. And what this process will take already started 6 months ago, and it will complete by end of next year. And then the Bahraini will have the best, the data-based, evidence-based, the medical, the health insurance, as well as personal health record system. And certainly what I understand, the primary healthcare the system in Bahrain is so well designed, well functioning now, with the new IT technology supporting the sharing the personal health record throughout the whole system, plus the Dr. Kim mentioned about the drug utilization review system, that is DUR, and here is building DUR system in Bahrain, and that also shows that all the prescriptions, drugs that the patients has been prescribed, all the drug history, as well as effect and the side effect of drugs will show as well. And so I think what's happening here, as I mentioned before, the bilateral collaboration or multilateral collaboration, the learning from the country who already invested a lot to build the system, and then also certainly that you understand the in terms of sharing the medical records entire country nationally is not happening in Korea. Not that we don't have technology, but we have some the issues. So we can implement with the country who has which has so strong the aspiration and the passion to serve its people better with low cost. So certainly this sort of work is very much the bilateral and the multilateral. And the UN certainly has WHO and has been also very much a leading figure to promoting the UHC. But actual implementation had to be local context. Thank you.
Okay, and I think on that note, we can wrap up this session. We want to thank Professor Kim Tae-hyun, Sheikh Mohammed bin Abdullah Al Khalifa, of course, Deputy Minister Dr. Kim Kang-lip, Susan Myers from the UN Foundation, Commissioner John Ryu, of course. And I think on this note also to thank everybody who's given up their time and invested in themselves over the last 2 days. As we said, it's a great opportunity to be led by figures like Ban Ki-moon and Heinz Fischer and Antonio Guterres, but really with you being here and participating, especially in these town hall debates, you've really made it something very special, not only for yourselves, I hope, but also particularly for our speakers who've come from across Korea and, of course, around the world. So we welcome you back. Get the dates down. You think about it. Valentine's Day 2019. You will not be going on a date. You'll be coming here for the next GEEF, and that will be February 4th. See, I don't even know when Valentine's Day is. That's what happens after a while when you don't have plans. February 14th and February 15th, 2019. And by that point, we'll update you 6 months ahead of that high-level meeting on UHC. Thank you very much, everybody, for coming. Thank you to our speakers throughout the last 2 days.